Welcome to all of you. Warm greetings from Chennai to participants across India and the globe. Welcome to the 7th edition of Healthcare Insights powered by RedMed and hosted by LBN Tech Solutions and All Ladies League. I am Megalai Senthilkumar and I head LBN Tech, a digital marketing company, and I am the host for this evening. Today's Healthcare Insights topic is Elder Care, Universal Problem, Solutions for India. And our expert speaker, Dr. Thanga Prabhu. Welcome, Doctor. We are so honored to have you here in our midst. A little bit about Doctor. Dr. Thanga Prabhu has 30 plus years of healthcare experience working in India, Abu Dhabi, and United Kingdom. Among other achievements, he has authored a paper for the UK Parliament Health Select Committee in 2005 titled The Utilization of Telemedicine and Its Future Potential for Improving Services. In a decade with GE Healthcare IT, he has worked with product development, implementation, and commercial teams as clinical director for South Asia. In 2009, multiple ICUs and OTs, operation theaters, were digitized for Fortis Healthcare under his leadership. He was instrumental in creating a portable health record with GE GRC Global Research Center USA and St. John's Medical College, Bangalore. He is currently VP Clinical Informatics in RedMed Inc., advisor sjhif.in, and consultant CARA, QARA, and IP, Quality Assurance, Regulatory Affairs, and Intellectual Property. He is a member of the EMR Interoperability Standards for India Expert Committee formed by the Health Secretary Government of India. He is a regular public speaker, continuing to build digital health cadres by delivering invited talks on medical informatics nationally and internationally. You can know more about him in his website, edrprabhu.com. Venkat, you can put that on the chat box. And moderating this session is founder of RedMed, Jay Srinivasan. Jay is very popular, especially after we launched Healthcare Insights, and he has a fan following. People love his moderating skills. So last session you were not there, and this session when you were there, when the flyer went around, people said, hey, Jay is back. So I'm sure you have people looking forward to your moderation, Jay. Jay has 30 plus years in the healthcare industry. Currently, he, along with his wife, Sandhya Rao, leads a connected health venture founded by him, which is RedMed Health Systems. RedMed focuses on enabling affordable preventive care that promotes wellness, early detection of chronic disease, and prevention of infectious diseases. Jay is a co-author, Internet Commerce Metrics and Models in the New Era of Accountability. He is a blogger on business models, business history, technology, and competitive dynamics. So welcome, Dr. Thanga Prabhu and Jay Srinivasan. The floor is all yours. Before I hand it over to you, participants from across India and the globe also, the moderated session will be followed by the Q&A session. So if you have any questions while the moderated session is going on, please go ahead and type it in the chat box, and the expert speaker will be answering all the questions one by one after this moderated session is over. So welcome all of you, and Jay, the floor is yours.
Thank you, Meku. Appreciate the introduction and appreciate Dr. Thanga Prabhu joining us today. We have a distinguished doctor, academician, as well as an industry participant who has been at the forefront of many of the things that we are beginning to hear today in these days in relation to healthcare. Thanga has been known to me for several years, and I consider it fortunate that he's reachable and has always given his time. Welcome, a warm welcome to all the viewers here today from wherever you are. We hope you would find the show interesting and something that you have takeaways for. We hope we are able to cover sufficient ground, and your Q&As in the chat box, any questions you might have, please post them there. Around the midway point, we would also be conducting a short poll. This is something that Megu and I decided upon. It's a very quick, easy poll. You'll just be asked to give some binary answers, and that will determine the kind of people there are today in relation to the context and the topic of our discussion. Welcome everybody again. Thanga, nice to have you here today. and let's get on with the show. My first query to you, it's more of a generic query, is when we talk of elders, we have titled this elder care. When we talk of elders, we also hear the word senior citizens, and I suppose most of us have an idea whom we are referring to. What do you think for the to stage this topic today? What do you consider as elders in your mind as a doctor?
Thank you, Megalai and Jay, and the wonderful audience that we have here. So this is a very important topic that not many people were talking about this subject. So this is very timely and apt for us to bring awareness on this session. To start with, yes, you need to define what we are talking, because we don't want any ambiguity in the subject that we are talking about. Elder, geriatric, old age, all this, is defined in different ways in different geographies. So in India, 60 plus is considered as senior. In the US, it is 65. There is a segment 80 plus, which is called as senior or elder. So we can actually classify them into 60 years and above, 65 and above, and 80 and above, because as I said, in the US, 65 is considered as elder for some reason. And when with time passing and with these elders actually being healthy and their cognitive abilities intact, there is no reason for somebody to retire at 58 or 60 years. So the general thinking is these people should be allowed to be active for as long as they feel they can be productive. So the definition of that elder is actually shifting. So today we are talking about India. So we will be talking about the 60 year and above and the 80 years and above. And just to give you an idea of the numbers that are there, it's about 8% of the Indian population for the census of 2011. It is increasing very rapidly, and it is expected to touch about 20% by 2050, which is 30 crore segment. That's a huge number of people we are talking about. Hope that gives you an idea of the size of the segment that we are talking about.
Nice. That was good to know. The media currently lets out that we are a very young country. India is a very young country. The common statistics being put out is that over 50% of the population is less than 35 years old, and under 25 years old, and something like 65% of the population is less than 35 years old. So at the moment, we are a very young country. So oftentimes, the question of elders gets brushed away or put in the background. So when we look at elders as a segment of the demographics, in your mind, what are some of the common problems that we have to consider in regards to elders along the category that you described, chronologically speaking?
Correct. No, there is no disputing the fact that we are a young country and the so-called demographic dividend is there, and we are actually blessed to have this amount of young talent. But please remember, we are also a huge country of 1.3, 1.4 billion people. That is where the dilution happens. Everybody talks about the young population, and we are not talking about the rapidly increasing number of people who are moving into this 60 plus age group, which is, as I said, going to touch 30 crores. So requirements, and each country And within India itself, you can see that, every state, and probably there is a huge amount of variation in how these things are handled. So that is the reason why it is important for us that, if you look at it as a percentage, yes, the country would be young. But if you look at it in absolute numbers, there is a significant number which needs to be addressed. So that is where the size of the problem is. Now, coming to some of the common problems or the issues that people in this age group experience, geriatrics or elder care or old age medicine in itself has become a specialty now. Thanks to work done at Madras Medical College, Professor V.S. Natarajan was a pioneer, and he started our patient clinic first, and then went on to start inpatient services, and they also they started inpatient services, and then they also have a full postgraduate program going on now. All India Institute of Medical Sciences has got postgraduate programs. CMC Vellore has got postgraduate programs. So the awareness has come in, and a little bit of effort has started, but this is not enough. We need to do more. Now, what are the common problems that people are experiencing? We must remember that there is a general decline in all functions of the human body with time. This is part of aging, right? So there is a general decline in all functions. What we call as activities of daily living, waking up from the bed, brushing your teeth, finishing off your morning duties, and having food, having a cup of tea, chores. These become becomes difficult, and there is a general weakness in the muscles. And if they are not mobile and they are not walking around, and if they are completely bedridden, then there is some amount of muscle weakness which develops over a period of time. There is.
I want to interrupt you a bit.
Yeah.
Some of our users are saying the voice is not very clear. Could you speak a little louder, if you don't mind?
Sure. No, I'm on full signal, so.
Okay.
I guess this is the nature of internet. So though we all will be having a good coverage, we cannot assure that the same experience will be available to everybody. But I made sure that the network is full and I don't have choppiness. Yes, so that's why I put mic near my mouth, because if I look this way, that way, yes, this observation was there. So hopefully now it won't happen. So muscle weakness is there. There is a laxity in the joints, so they tend to fall. Fall is a very common problem in elders. And then they have dislocations, they have subluxations, which is a minor movement of the joint where the joint becomes unstable. Strictures develop, which is like contractions, if they are not moving their limbs for a very long time. And those are problems which lead to other complications. There is a general cognitive decline, though you cannot universalize it, but there is a general decline in cognition in people as the age advances. Hearing is diminished, and what we call as neural deafness sets in. Vision loss is there. That also is part of the aging process, for which a little bit can be done, but many times it is just the normal macular degeneration which happens with aging, and they have to accept to live with that amount of vision loss. The amount of intake, as in food, also comes down, because the general metabolism rate comes down. So the amount of food that people take is actually reduced a lot, and sometimes it becomes too less, and then that also causes nutritional problems and other problems. And they actually lose appetite, they lose taste, they lose smell. So flavor in food is a combination of taste and smell. So if your taste and smell is gone, then the food is bland. This is a common observation among elders. No amount of salt or spices in food is enough for them, because they always complain that it's not spicy enough. And then the reason is not because there is no spice in the food, it's because their sensing abilities are a little bit reduced. So these are all some of the reasons why the appetite goes down, and because of that the intake goes down. They may have incontinence, they are not able to control their urine, usually is very common. Sometimes bladder also. The opposite, constipation, is also very, very common in old age. And so these needs to be addressed, knowing fully well that this is almost a normal part of getting old and aging because of these conditions. One of the most important problems is social isolation. And that social isolation, when there is no communication with anybody, leave alone the family, anybody, so that they are all alone, and there's nothing to do whole day, that causes depression, that causes delirium, which is an acute confusional state. So sometimes they lose track of time and place. And then of course we know about dementia and Alzheimer's, which are conditions which are organic conditions in the brain, which cause more severe cognitive decline. So these are some of the common problems. And one important thing that we need to remember is there is a concept of EOLC, which is end of life care. So they may have cancers, they may have chronic diseases, they may have conditions which require a completely different set of medicine called palliative medicine. And palliative medicine is not about curing somebody, but it is about making the life livable for somebody who is destined to die, somebody who is 80, 90 years old, who is having multiple medical problems. There are certain subtle things that needs to be done to take care of them at that age, and those are some things which also need to be taken care of. So if I can classify these patients into 3 groups, a large percentage comprises of your healthy, capable of independent living, who are the normal elders. That's a large percentage, thankfully. Then we have the normal with medications. Usually they have diabetes, hypertension, some amount of heart problems, Parkinson's, so they are on polypharmacy. They are on all these medications, and they have to take these medications regularly, and somebody has to be there to help them with these things. Then you have the bedbound, who are unable to walk, and that is a completely different segment where the amount of care that is required is much more. So they tend to have other kinds of problems for which the care would be a different thing. One thing which we need to remember, and this is completely ignored by the society, is abuse, elder abuse happens in India. It happens everywhere. It happens in villages, it happens in cities, it happens in Chennai, it happens in Bangalore. Nobody, can say it doesn't happen in my neighborhood, right? We don't see it, but it happens. And why that elder abuse happens is a very important subject, which is, being researched in Western countries, in very good institutions, because it's a complicated problem. And but the fact is, we need to remember that elder abuse does happen. There is a report from HelpAge India in 2015 where they actually found out in a study that daughter-in-laws and sons emerged as the major abusers. This might be a coincidence because daughter-in-laws are mostly the ones who are taking care of the elders. So that might be a coincidence. And in certain cases, they found daughter and grandson were also reported as abusers. So these are some things which we have to keep in mind. And when we think about taking care of these people, we need to be aware of this.
Just had a message from one of the audience members, Senthil, saying that June 15th was actually Elder Abuse Day.
Right.
So
that's right.
Okay. The fact that most of us, including myself, didn't know about it is quite a testament to the fact that we all live in ignorance to many of these things.
Mm-hmm.
Activities of daily living, Dr. Thanga, I believe that's what you said, ADL.
Yeah.
it seems to cover a wide swath. You included things from what I would say physiological measurement to cognitive measurement to metabolic measurements. Are these captured in any way? I mean, can these be actually captured in a questionnaire, standardized way as to what are the ADLs that different senior citizens can rate themselves to, or the doctor can rate them to?
Yeah. These are all standard, well-defined structures. I'm not, creating anything new.
Oh, absolutely.
These are all existing things, which are available. But for our conversation, for this conversation, activities of daily living is what we do without even thinking. When we are not in that age category. But when we move into that age category, when they get up from the bed, getting up from the bed itself is difficult for them.
Right.
Because the back muscles are weak. They need somebody to help them get up. And then a short, 10 steps to the toilet.
Mm-hmm.
That is a difficult thing. So like that, yeah, activities of daily living is just a normal life that a normal adult person lives, and how those get impacted.
So it's a measurable, quantifiable thing with regards to different classes of elders. You started out by saying there are at least 3 classes of elders: those who are very healthy, and independent, and then there are people who are on medications, which is a function of aging. As you grow older, one gets to have something or the other, and you're taking medications for it. And then the last category, I believe you said, was the totally bedbound and who need a lot of assistance and so forth.
Right.
So each of these can be quantified in terms of ADLs.
Yes, we could.
Okay. All right. Your comment about abuse in the home, and it doesn't necessarily have to be in the home, right? I mean, the abuse can happen outside of the home as well, within institutional settings, right?
Yes.
Okay. That is very troubling. And what is being done about these things? I suppose all of these are hidden things, right? They remain hidden to the most part, is what my guess would be.
Yes.
Okay. So we talked about different categories of elders, and we talked about ADLs, abuse. How can society be able to take care of elders across the spectrum of all the different kinds of elders? Do you have any sense of how this is being addressed, either in India or outside?
Yeah. So if you ask me, are we as a society taking care of these elders, and is the society, our society, Indian society, how good are we when it comes to taking care of them? I would say I have been working in an elder care home since 2005 here in Bangalore. I volunteer there, and the kind of things that I have seen and experienced there, I go there on Saturdays to run a clinic for them, has actually given me a very deep insight into the kind of things that happens in society, which is not visible outside to the normal population. This is an NGO, so not much actually. The elders who are actually getting, good amount of care from their immediate family and, circle of people who are providing care is not a very big number. So there is a very big population who are silently suffering in loneliness, and it's a fact, right? So as a society, we have not actually done much. So that remains a fact. And elders are living alone, and this trend is increasing.
And when you say living alone,
if you look at
not just physically alone, but within the family, but living alone, isolated.
Well, that's a minor category. When I say living alone, what I mean is either the children are in a different country or in a different city, or probably in the same city, but they are living somewhere else. And what is the frequency at which they are visiting and coming and looking after the parents or the relatives that they are caring for? There's a huge variation. Sometimes it's a couple of years, sometimes it's a couple of months. So there is a huge variation in that. So that, what does that mean? That means that these people are all by themselves.
Mm-hmm.
And some of the reasons for that is the increased life expectancy, good or bad, healthcare has become better, so people are living longer. Reduced fertility rates, that is adding to this problem, because then as compared to about 30, 40 years ago, when people used to have 3 or 5 kids, today having 1 or 2 kids itself is a luxury. So we are seeing that, the number of, the reduced fertility rate is adding to this problem, because there are less number of people to actually take care of the aging population. And then changing family structures. When we had a joint family system, that was a very different system, where the elders had 3-4 levels of hierarchy, and they had their own defined spot where they were the very wise people who had certain responsibilities and taking care of babies and being like an advisor. They were not necessarily expected to do any physical activities. So that whole ecosystem is gone now. Nuclear families means the people who are living this life, they are also alone, and the people who are actually out there to make a living and earning and doing that, they are also alone. Because if you look at these youngsters who get married, have a kid, both of them are working, and they have to go and find somebody to look after the baby, or find a crush or something. So we are seeing a massive social disruption in the way things have been happening. And the villages are not bereft of this problem. So what is happening in the cities is also happening in the villages, because those kids are also coming into the cities for jobs and for other economic reasons. So the changing family structures is harming it. Women joining the workforce has also contributed to it. Not that we need to complain about it, but we need to take that into account and see how that can be mitigated. And the middle class moving abroad is one of the other reasons, because that results in this kind of huge segments of population where it is just these elders all by themselves.
One of my observations for the last several years, and is that every time I visit Chennai, I have noticed that something like 30 to 40% of residents within an apartment complex are generally senior citizens living alone, because the kids are all away, as you said. I've not found this to be so much of an issue here in Bangalore, but that might be just my perception. But I've noticed this as a stark metric in Chennai. And I've always been curious who takes care of them, because they're living alone. And as long as they're active, they're able to take phone calls from their kids, wherever they are. They say, we're doing all right and things like that. But it's when things break down, when they have a fall, when they have a disc relocation or surgery or something like that, one of the two is knocked out temporarily, at least. And the kids are not in a position to come and give care and help. And so they have to manage themselves. I've seen this myself many times. And it does seem to be an extraordinary problem that is appearing right before our eyes, even as we speak. So it's a big issue.
You are right. I mean, Bangalore is not exempt. Bangalore also has this population. The segment that you have probably seen may be the de novo communities where mostly youngsters are living. But if you go to South Bangalore, which is predominantly where the old traditional Bangaloreans live, not very abnormal for an elderly couple to be living in a independent house or a bungalow all by themselves. Now that leads to more problems, because there are criminals, there are people who are roaming around, and they know these two people are just lying there. It's a easy picking for them, and once in a while, the crime also pops up its ugly head. We find that people walk in and strangle them and walk away with whatever they can find. So yes, it does happen. I mean, in Bangalore also. It's a
and I suppose all across the country. It's not
Yes.
just Bangalore and Chennai.
Yes.
Okay. So nuclear family, two-income households, kids growing up alone, increasingly is relegating the seniors to fend for themselves, pretty much. Right?
Mhm.
That's the outcome of all these so-called modernization or modern life that we are experiencing today.
Mhm. Mhm.
And India is not alone in this. So when we talk about these issues, we have to inevitably consider what are the constraints in the ability for society to come up with some solution. So there are examples abroad, very few countries, of course, and you could elaborate on this, which seem to be doing a relatively better job, despite having very large senior citizen populations, right? So what is it that we could do or even emulate from these countries? Or how is it these countries, these selective few countries, what are they doing that addresses many of these issues? I'm hazarding a guess here that the problems are not with India alone. This is not unique. It's across the globe. And as a country which, becomes wealthier and more people are going into jobs, you're going to expose many of these issues. So India, in a sense, is not alone. What are the constraints for us as a society to come up with some solutions, and where can we look towards to emulate those solutions? Any thoughts on those?
Yeah, it's not a problem unique to India. This is a global problem, and some of them have uh, started working on trying to mitigate some of the issues that are there. Like we discussed, Singapore, Taiwan, Japan, in Asia. These are countries where some amount of serious work has gone into it. And in the Western countries, UK, where I lived for 2.5 years, this is actually a very big component. UK actually has got a very good edge over other countries because the NHS is free of payment. It's a free service, and there they have a component of elder care. So they have trained geriatric people and they have community support, and so it's being solved by different ways in different countries. We don't necessarily have to do the same things what they are doing, but definitely there is a scope for us to learn from them and emulate some of those learnings into our whatever solutions that we are thinking of bringing in. So the constraint itself is this rapid emergence of nuclear families and living alone, and that I don't think we can reverse, right? That's not in our hands. That's a one-way path, and it's gone. The joint family system is gone. We can crib and cry all the way amount we want. It's not coming back anytime soon. So we have to think of what are the solutions going forward, accepting that this will remain. One problem that is not there is the lack of care providers. So whether it is somebody who is capable of taking care of themselves, they are able to do their activities of daily living. They also would require some help with medication and some of these activities they will require. So that lack of care providers, currently the people that actually are sent out by these NGOs and these guys, they are just people, they pick them off the street and they just send them. They are, many times they are completely illiterate. I was shocked to see they don't even have numerical or literary skills. They can't read any language. They can't read any numbers. So imagine giving some person like that a box full of medicines and expecting them to ensure that the person would actually take the medicines correctly on time without mixing it up, which will cause more problem. So if you get into it and do a research, and we'll be finding that there are lots of these bloopers going on, which need so. That's a constraint, the care provider, and the care provider itself. When you look at it, it's not just helping somebody get up from a chair or giving them a bath or feeding them. I believe even when we take care of our immediate relatives, It will help if, we can go for a 3-day or a 1-week refresher course where we are taught basic things. I mean, not everybody is medically trained or healthcare trained. What are the do's, what are the don'ts? There is a certain way to help somebody get off the bed. There is a certain way to, help somebody actually, lie down. There are these things, position matters, and how do you help somebody. So many of these things would actually make sense if, we can get that part somehow, whether we do it in person in trainings or we do, sessions online to create these things. Definitely it will help because when you actually are faced in that situation, many times you're lost, because I mean, I'm a doctor. I've worked in old age, wards, but when my turn came, I was stumped, in few places because I didn't know what to do. So there is a strong case for learning those things and moving forward.
It's a very interesting observation, calling for a 1 or 2 day course, even a 1-day course for ordinary families to appreciate what are the issues involved in taking care of elders. But I'm also hearing another point of view from you that many of these problems stem from the fact that we don't have requisite manpower
Yes.
to cater to elder care. If that is so, I mean, we are asking for training sessions when we don't have the other element as well. So we need to fix all sides of the solution, right? What would constitute, when I say all of them, for lack of a better word, let me use the word stakeholders, because that's a very common phrase used in the entrepreneurial community. If you look at it in terms of stakeholder interest in this particular issue, that of elder care, can you identify what those stakeholders would be to be able to provide all of these different kinds of services?
Yeah. So let's identify the stakeholders, not just the ones who will provide the solutions, but you look at the the entire picture. To start with, it is the elder themselves.
Right.
So being elder doesn't mean that you are off. Like when you walk into a hospital, you have a patient's charter and you have a doctor's charter. So it takes two hands to clap. You need both people to cooperate. Okay. So you need cooperation from the elders themselves also. They can't be adamant and say, I'll watch TV at 2 o'clock in the night. Right? And they have these, whims and fancies. I don't want to take baths today. Imagine, doing that in a warm, humid place like Chennai for, 4 days if you don't. So there is, to start with, the elder themselves are a stakeholder. Start with them. Then you have the family caregivers. So when I say family, it could be children, it could be the daughter-in-law, son-in-law, it could be brother, sister, all these people. So the family caregivers, that is one big group of stakeholders. Then you have the third-party caretakers, who come in sometimes for charity they work, or most of the time it's a commercial thing. They are paid a fixed salary and they work for income. They come and provide the care, and those people need to be trained, and this spirit has to be inculcated into them, that what they are doing is they are dealing with humans. This is where that elder abuse comes. There's a small snippet here is like when we feed a child, if the child doesn't have the food, we will try, but at a certain point we may just give it a small smack and then say, go and have your food. When they do that with the elders, that is abuse, right? And these guys don't understand that they are not doing it intentionally, because with old age their cognitive limits are there. So for them it is just a job, a task to be done. So it can go all the way from that to severe abuse, where in the emergency we see patients who come with fractures and big hematomas and all that. So it can be a very big problem. So those third-party caretakers need to be. That's where you bring them into a medical college or a hospital or a place like that. And a healthcare worker has to have that first compassion as the first qualification. If you don't have that, then you cannot, provide care, because that is something which will have to come in, that very important part. So the third party caretakers. Then you have the institutional facilities. So institutional facilities come in all shapes, sizes, cost. So you have government-run institutions, you have predominantly NGOs, you have religious institutions, many charitable institutions. Then there are very expensive, pay-for-service institutions also available, where for fixed amount of money or a monthly subscription you pay, and these kind of services are provided. So that is one big segment. Then you have the commercial elder care residences. This concept is, again, I've seen it in UK. It's called a secure accommodation. It's like a whole flat of say 50 or 100 apartments, and you have only elders living in that whole apartment. And you'll have a community kitchen, you'll have an in-house, manager, you'll have people to run errands for you. You may have a medical officer also, either inside or visiting them. So the good advantage there is crime is reduced, because anybody and everybody cannot walk in there. And when they have to go out, they will need an escort. They need to have somebody to take them out. So they are, and people who have Alzheimer's and dementia who tend to get lost, they are safe because they cannot go out of the main exit. So within the apartment, they'll be able to move. They won't be able to go out. So those commercial elder care residences are there. Then you have the gerontech vendors. So when I said gerontech, gerontology is the study of old age, and technology which is used in old age, all put together, we call it as gerontech. And this gerontech,
these are like anti-skid floors and grab bars and things.
Yeah,
like
it's a huge industry. Currently, the medical supplies fellow, the surgical supplies fellow will have a little bit of these things available. But then, this by itself is an industry, for some entrepreneurs or people who are looking at a business idea, setting up shop and just dealing with this itself is a very, very good business, because, the flooring has to be anti-skid if it is for a house. Then there are these railings which are there on the sides in the bathrooms for them to hold on to. And it's a huge thing. Then there are these call systems which are available. So if that person wants the attention of somebody, there may be a bell, or there may be a two-way intercom system, or so different technologies are available, and then these vendors are one of the important stakeholders, because they are the ones who day-to-day deal in these things, and they are the ones who will be innovating and coming out with more and more new technologies which could be brought in. And the most important stakeholder here is the healthcare system itself. Currently, healthcare system ignores this population. Shocking.
Yes. Hello.
Sorry, lost you for a while.
Yes, so could you roll back and repeat what you said?
Yeah.
You were talking about
what I said was healthcare systems by themselves are, not participating in this area at all. You look at all the major hospitals, in our cities. You see, if you have a department of elder care medicine, you see if you have any consultants working in that area. Not many, actually.
So I want to ask you, why is that so? We started out by saying who the demographic is, and it's for India, even if it's 8% or 10%, it's a very large number. And a good significant portion of that has the ability to pay, at least through the kids. So when you have such a visible opportunity, why is it that the healthcare system, and I've seen this myself. I mean, I've talked to clinics, and very few clinics in Bangalore, for example, have a geriatric line of business, if you will, catering to senior citizens. Why is that so? I mean, from a purely business perspective, one looks at it as a possibility to engage with senior citizens and therefore to have a sustainable revenue. I'm just looking at the business perspective in order for that healthcare system to provide solutions. Why is it we are not seeing that?
No, because nobody is actually seeing the bigger picture. This is where we need a ecosystem approach to it, instead of having a bits and pieces approach, right?
Okay.
So if you look at it, the problem is multifactorial. Okay, there are multiple parts to it. There are workable solutions. We need to aim for a win-win for all. Deficiencies and downsides of each of these possible solutions needs to be looked after. Yeah, and there the role of elder themselves, caregiver, health system to manage the medical problem. So why I said healthcare system is these facilities either provided in the community or provided in a dedicated facility like a secure accommodation or in a institutional setup will need access to secondary and tertiary care from a healthcare system.
You're saying
So
this
that
does not exist.
this does not exist.
Why is that?
Predominantly, it doesn't exist.
Okay.
We have
That's
a
so?
good working model in St. John's Medical College.
Uh-huh.
That's a very unique model. I'll talk about it towards the end a little bit. That kind of a model is required. Many times what happens is people miscalculate. They don't foresee that in old age, healthcare is the most important requirement.
Mm-hmm.
And having access to a good healthcare facility for secondary and tertiary care is a mandatory thing. It's not an option. Right?
When you say mandatory, it's a government legislation.
No. What I mean is, like you look at, where the elder care homes are coming up in Tamil Nadu. They are all coming up in Coimbatore for some reason. I don't know why. Probably the weather is good, or it's taken on a aura around it, and there are a lot of people going there. But then when I talk to these people and I ask them what happens if one of the people need attention, they have a problem. Then they put them in an ambulance and then they bring them into the city to provide care to them. And if that is about a 60-70 kilometer ride, you can imagine, how difficult that is going to be. So that is not a workable model. You need a regular interaction with the hospital setup, with the healthcare system setup. Both government and private, could be able to help there. And when we talk commercial models, of course, the private sector will be doing it. But then there is a good, established model which is working here in Bangalore, in St. John's, and that looks to me like a very good model to replicate for other places also.
So I would assume the kind of ideal model that you are referring to would be an integrated model, where
Yes.
different parts of the requirements are met easily with
Yes.
efficiency and speed.
Yes.
As the need arises, right?
Yes.
Okay. And right now we do not have, possibly because every little component has grown in isolation without
That's
so to
right.
speak, talking to each other.
That's right. So each person has gone and solved his little bit of the problem. A builder has gone and created a community somewhere near Devnalli or far away from Bangalore, because real estate is cheap, and then the thinking is elders don't want to be troubled by all the busyness of the city life, so they need a peaceful life, and this is how they go and put them up there. But then what you have lost is this connect to the healthcare.
At some point, each of those pieces would wake up and realize that hey, we ought to be connected, and right now we are not. So we are not servicing the needs of the particular segment effectively. Shouldn't they wake up to that? I mean, what is the difference?
No, they should. No, they should. So that's the whole idea of us talking like this. I hope we have in the audience some people from these builder community who have actually, and these are big builders. Okay, and these apartments and bungalows are not cheap. They are all expensive property, right? But it was a big failure, and this happened about 20 years ago, 30 years ago. They went and built, and then they gave up. So it's not a very viable project now. So my take on that is, I'm telling them, you guys only concentrated on the building, right? Maybe some anti-skid flooring is also there, but did you actually think about how you're going to provide the medical facilities there? Did you figure out the other bits and pieces? Okay, that bit they did, but then some other people figured that out. We do have few companies who are providing elder care like Portia and Kites, and there are few people who are providing that, but then they do their bit, little bit, so there is this whole ecosystem approach which needs to come in, and there if we can sort of put everything together, we might be looking at a at a reasonably acceptable solution.
So the ecosystem approach here would be, on the one hand, create standards and training so that the human resources needed for the appropriate level of care is furnished, number one. Number two, for clinics and hospitals to appropriately cater to the segment in a focused manner. That would be two. Number three would be for a different segment of the ecosystem to be able to provide the day-to-day things that are needed to have a safe life. And that would include all of those, anti-skid floors and grab bars and things like that. The builder community and the architectural community would address the issue of, hey, is our building built in a manner that provides a safe living for seniors, number one. And number two, are we well integrated to the other things in the form of some hub and spoke kind of thing? A fair way to describe this ecosystem that you're talking about?
Yeah.
Okay. So if the ecosystem is the hindrance here, is the constraint here, what can we do to help build, apart from talking in a forum like this? A webinar certainly can communicate and create more awareness, but I suppose it needs more than just that, right? It needs probably a degree of government involvement, a degree of business associations to focus on the issue and talk to other parts of the ecosystem, and so that they can all invest in this together. So is this being done in India anywhere?
No.
And we are living in a major technological city.
Yeah.
Okay. And how would this solution look like? If all in an ideal utopian world, we suddenly wake up and find that all the bits and pieces of the ecosystem in Bangalore have suddenly woken up and decided that they are going to provide a comprehensive solution for elder care, and they have also roped in the government, and everybody is very keen, very motivated. What would this ideal solution look like?
Yeah, I mean, who does it? Maybe that they can decide, and whether the government or the private guys do it. That part can for now let's park it.
Mm-hmm.
You have to address it in 4 concentric circles. Okay, take the elder, look at the needs of this elder in different age groups: 60, 70, 80, and 80 plus. Right. So that is one. Then look at the caregiver. Do we have caregivers? Are these people trained? Is there even a minimum amount of training that these people are getting? Do we have some minimum eligibility criteria for them? Like, minimum literary skills, so that you are able to read a prescription, you are able to follow a brief communication, you are able to respond in case of an emergency.
So we are looking beyond the family when you say caregiver. Outside of
no, I'm saying when we say caregiver, it could be both. You can't assume that a caregiver in the family would know all these things.
Okay, got it.
My experience has been that we need to train the caregiver, even if it is immediate family, on many of these things. So I keep getting calls. So recently a person, his dad was having advanced cancer, and for 3-4 days he was calling me, and we were trying to help him out. But it's his father, but he doesn't know how to handle many of these things. Like, there is severe pain, and just the normal painkillers are not enough. So you need to do a little bit more. And so they need, whether it is immediate relatives or not, a caregiver. I'm just keeping it as a segment, as a caregiver. Then you have the health system. Then you have the gerontech guys to solve specific segments. So all these things can come as, concentric circles, so that they interact and provide some kind of solution here. And this cadre of people, which, with some minimum amount of training, with some kind of certification, will definitely raise the quality in levels of care. And today, if you ask me, is that available? It is not available. The ASHAs and ANMs which government creates are meant for public health purposes. Mm-hmm. So ASHAs, for those of you who don't know, are accredited social health care activists. They are usually girls from the local community who are trained to go and do door-to-door checks, and it's all public health work they do.
The rural
health awareness.
In the rural areas.
In the rural areas. In an urban, we do have. And then the ANMs are a cadre just below the nurses, auxiliary nurse midwives. So they are, this is not that cadre, I'm telling. This is even below that, right? We don't need the specialized skills that you would require at these levels. It's a healthcare oriented person who knows what to look for, how to, take care of these people. So that elder care segment, cadre of people to take care of elders, that is missing, and that needs to somehow come up. To do regular checkups, access to secondary and tertiary care, then technology can play a big role in addressing many of these things. So it's not like you need somebody to keep visiting these homes all the time. We can use telemedicine. We can use regular phone calls to call up people and check with them if they are all right, which happens in UK. And in UK, we tried CCTV cameras to monitor people. CCTV cameras were found to be too intrusive and people lose privacy. They don't like it. So then we switched to infrared cameras. So infrared cameras will keep track of people. If there is no movement beyond a certain, fixed duration, then immediately our call is triggered and, somebody calls them and checks with them if they are doing
This is
right.
in the home.
In the home.
Not in an institutional facility.
Not in an institution.
Okay.
So there is definitely a place for technology to monitor and interact with these people and keep in touch and work with them. Access to reliable supply of medicines is a very important point, which many people completely miss out on. Generic medicines, if available, definitely, because like I said, polypharmacy is a factor, and these people are on a lot of medication. Getting medicines on time, and keeping that supply chain active is a major requirement, so that they don't miss out on these medicines. Otherwise, somebody has to go to the pharmacy and get it, and they may not have stock and all that. We can, when you provide it in an institutional care facility, we can take care of these things. It should be possible to do it. And this is just an idea for people who are thinking on entrepreneurial ways of doing it.
Okay. So, Dr. Thanga, we have about roughly 10 minutes. I think we can stretch up to 5 to 10 minutes. So let's quickly run through some of the issues that all these bring up. One is the role of the government. Where are we in terms of legislations and standards and training requirements today? I know healthcare is a state subject. For those of you listening in, healthcare in India is a state subject, largely controlled by individual states and paid for by the state budget. But given all that, where are we today? And I'm sure there is a variance across states as well.
Yes, there is. Yes, health is a state subject, you're right. When it comes to infectious diseases and national programs, then the central government runs it as a national program just to have a consistency across the country. Government of India has been active thanks to the work done in AIIMS and in Madras Medical College and these places. Awareness has been created in the government circles, and Government of India actually has passed a law called Maintenance and Welfare of Parents and Senior Citizens Act in 2007, right? So neglecting an elder is a crime, right? It's a crime in India. So the law exists. So it's already law.
The crime by the family members?
By anybody. By anybody. So I mean, how you enforce this law is another problem.
It's an issue, yeah.
It's another problem. But if somebody is found neglected and we know that they have children or immediate relatives who are supposed to be taking care of them and they are not, it is possible to actually use law to try and address it. So the government has done that bit. Okay, so the government has said that it's not right for people to be neglected. So that part is there. The law is there, 2007. Then we have a national policy for senior citizens, which was passed in 2011. So they have actually gone into quite a lot of depth, and you know that they have preferential rates in income tax, and they do have some amount of, for the BPL segment, they do have some kind of a small token amount which is given out to the elders. So the government is doing its bit on the policy side, and many things that was proposed that the state governments take up and do is still lying there. The state governments have actually not taken up many of these activities. They were supposed to set up old age homes and provide the care facilities like we have in England, and many of these proposals had come in, but then a policy is a policy, and implementing it is a completely different ball game, because that there are multiple priorities on the ground, and when they have to work on those things, somehow this sort of takes a backseat, and it's lying there. So
you spoke of one of the characteristics in the care of elders as being the amount of medications they inevitably take, leading to possible errors and things like that. But what about in terms of in the context of laws and policies that are coming in for the price of these drugs that are specifically meant for elders? Are there drugs which are discounted for elders, especially from people from low-income families and things like that? No.
Nothing exists like that.
Okay.
There is nothing like that right now. But that's definitely something which is required. And there is no special medicine for elders. It is the same medicines that are used for everybody. What I'm saying is they are on multiple medications on a regular basis.
Got it.
So they need to have a secure supply which is available to them. And if it is generic, the cost is going to be a little bit affordable. And there are government entities which are providing, like Jan Aushadhi, which is a pharmacy which the government of India runs. The prices are very, very reasonable, and they do have generic medicines. So access to these need to be provided so that they are not left without medication, which causes complications. If they don't take their hypertensive medicine, they're going to end up having a stroke, and their BP is going to go out of control. To handle those kind of things. And training is something which the government is very good at. So right now, all their training is on public health and health awareness, and they focus only on mostly on reproductive and child health, RCH, because their focus is to reduce.
You're breaking up, Thanga. Can you hear me?
Sorry, lost you a bit there. To some extent on infectious diseases.
Okay. So
if we sort of create this, awareness, and somewhere, the government health commissioner and the health secretary, this level people come to know that this group is talking about it, we definitely can engage with them and tell them that we need your help to, give us opportunity to create some of these cards, because it will solve two problems.
Okay.
It will create opportunities for villages, people who can get trained, get certified, and take on these jobs, because definitely and there is money on the table. In Bangalore, you end up paying anywhere from 25 to 30-40,000 to these people. So why not have a proper trained person do that and pay for it, rather than just pay this money and end up getting somebody who knows nothing.
Okay. So Dr. Thanga, we've got a few minutes. I would like to quickly roll this up and open the floor to Q&As that I'm sure the audience has. So you have said that there is opportunity, training is being done, and there is money on the table. And you've also given a very good description about what this ecosystem could look like and what it needs. So if we are to bring this all together in some form, to address or direct our attention to something that is my own pet peeve, is it possible to do a pilot in a small way that brings all of this together to get everybody excited that it can be done, and then once the systems and processes are well set up using the pilot, to replicate it elsewhere? Has it been done before?
No, it has not been done. But yes, it's a good idea. And we can have it in two segments. We can have one urban setup. We can have one rural setup. So there is major differences in how this problem is actually addressed in these two areas. And that would be a good way to actually create a working model to showcase that this is how it is done.
So last question to you from my side. Given the complexities involved in delivering care to senior citizens in a sensitive way that addresses the different segments within the elder care demographic, you had always articulated in our several interactions before this webinar that one of the things that would help in this regard is for such webinars to actually reach out to the various stakeholder components, right? What are your expectations in terms of what this can do, and how can we in the future webinars roll in those different segments, the different parts of the ecosystem, so that now there is not only an acknowledgement that a problem exists, but a fuller understanding of where the complexities lie and how they could interact together to mutually come up with solutions that are also lucrative for themselves, but also addresses the segment that we are focusing on, elder care.
Yeah, definitely. See, to start with, one should recognize that care of elderly is a legal requirement in India now. Okay, it's not an option. You can't just, this happens. Drop them off in the temple, just leave them in the railway station and disappear. Leave them on the road and go away. That's a crime now. So that awareness has to come. It's a legal requirement now. And living healthy is more important than living long. Okay, what I mean by that is people are living for a very long time now. But if they are going to be at the mercy of somebody who is going to exploit that situation, and if they are not trained, they don't know how to address that situation. Living long in misery is actually not a very nice thing. So living healthy is more important, and by addressing these things, we will ensure that people can live long and live healthy also. That's the whole idea. This is the principle behind how Singapore addresses their elder care population, which is like growing, much faster than our elder care population, because of the same reasons that I said. The youngsters are not, the fertility rates are pretty low, and the elder population is rapidly increasing. So they're coming out with very interesting concepts of how to keep them healthy, and and ensure that in old age they are actually not in any suffering. So there are patient support groups, and there are mutual learning experiences. So these patient support groups can actually, the caregiver support groups can have common circles where they can exchange notes among themselves on what they have done in their own individual ways, and the ways and means of providing care, to know the options as an elder. That is very important, right? So what are the options? I was just noticing that some of the audiences, posting queries on the side. What are the options? Is there a way for one to live in a house and get, the care delivered at the home, or end up in a institution? It's not a bad idea, actually. I mean, the connotation of old age home, somehow is very negative. Doesn't have to be that way. Some of these places are very well run and very, very nicely done, but that's a very personal choice one person has to take. And so what are the options as an elder? So that these people also need to be able to get access to that kind of information and make a very educated choice in how they want to live, the rest of their life after they turn 60.
Megalai, at this point, we can open up to Q&A. We've got roughly 15 minutes.
Yeah, sure.
So that should be sufficient time for Dr. Thanga to run through the questions and give his answers.
There are several different kinds of questions. I think the first one Bhuvaneshwari Natarajan, she says there are some situations where elder abuse the caregivers, the reverse, and give false complaints as elder abuse, misusing their age. Any comments as to how to address the grievances of the caregiver? Because caregiver woes are something different and they also need a lot of help. So, doctor, you have any solution to that? Because you were just talking about the whims and fancies of the elders, they are like second childhood. So probably they're just being adamant and, how to deal with this.
Interesting question. My first ball itself is a googly. Bhuvaneshwari, thank you for asking this question. I agree. It can cut both ways. Like all, laws that have been passed, anti-dowry act was passed, and because of that, there is a fair amount of, abuse of that law also. So it cuts both ways. The only thing is, I'm yet to see. 60 will not agree with you there. I'm sorry, but that's been my experience. And when you say abusing the caregiver, it could be a misunderstanding on the caregiver side. Like I said, when an elder says they don't want to, do something, they have a reason why, they are saying it, which is not very evident when you communicate with them, because they are hard of hearing, they can't see well, they can't communicate properly. So it's a simple, yes or no thing they say, and we most of the times misinterpret it. So when we actually talk to them and understand what is it that is bothering them, you'll be surprised. 90% of the time they will be right. So I think it's a matter of communication, and the relationship between the care provider and the person who is receiving the care, where we should not end up in this situation where they actually have to go and file a complaint. That's interesting. I mean, because as of now, I can tell you that the elders silently suffer this abuse, and when they turn up in the emergency with a bruise or with a fracture, or so we are trained to pick up these things, and then it is us who actually go back and tell the institutions that you need to take care of this person, because it looks like they are in trouble. I've not come across this situation, but if at all you are talking, and I'm sure you have a reason to bring this up, I think a good communication should bring out the truth in this. And if they are, like I told you, most of the time they have a proper reason for what they are doing. And if in case that is not there, then we'll have to figure out what is the reason for the complaint.
Okay, thanks for that. Punita, you want to talk something? Is it related to this, or can we have that at the end of the session? I think we can move it to the end of the session. We'll go on to the next. And there is a comment from Ravi which says, is old age home a solution? We have members of Sekirar Manolayam old age home, and we don't call ourselves as old age home. I'm also part of that advisory board of that retirement community. We prefer to call it as retirement community. We have several members here in this webinar, and thanks for joining in, Dr. Edil, Mrs. Kannagi Mani, and Mr. A.M. Swaminathan, Mr. Ganesh. We have the whole trustees here. Mr. Alanandar is also there. And so they have hands-on experience on running old age homes. Answering Ravi's question, why old age homes are still taboo? I mean, there are several old age, I should say retirement community, because old age home, it sounds, it is a negative word for many people. Isn't that a solution, like Ravi says? Because there are people going abroad, the children are abroad, they just cannot come practically. Why can't we, remove the taboo from our minds and make it like a, it is not a stigma anymore, because that social stigma is still there, sending elders to old age homes or retirement communities. So is old age home a solution? There is a comment for that. Old age homes are not immune to elder abuse. Somebody has commented to Ravi. You have to make careful choices. Well, there are some negatives everywhere, But I have seen some very well-run retirement communities in Chennai itself. They have, you were talking about, medical care facilities. They have ambulances, there, and it is all built in such a way it is very conducive for elders to walk about and absolutely safe. But these places come with a price tag. Okay, so people have to spend enormous amounts of money to go there. So the middle class and the people below that are left behind to fend for these old age homes, which might abuse also. So your thought on that, doctor?
You sort of answered the question. What thought do you want on me?
That is old age home a solution? This taboo, this societal taboo, will it go? What can we do? Because this seems like a solution.
The connotation, the connotation of an orphanage, of a palliative care center, of a hospice, of an old age home.
Yeah.
All these cliches are gone now.
Yeah.
Okay. I happen to live in Whitefield. We have a palliative care facility here called Karnashraya. Okay. And this is a place where terminally ill cancer patients are taken care of.
Yes, I have visited the place. It's beautifully run. I think they won this architectural excellence also, award also.
Yeah. It's beautifully run. So when I come across people who are in terminal cancer and they are, clueless because they're not able to manage things at home and the hospitals don't want to see them, they basically, don't know where to go. I guide them here and I have experienced that, when they come here, they actually benefit a lot from that. Similarly, the concept of, so the name may be wrong. The moment you say, old age home or an orphanage, that sort of paints a different picture in the mind. Right? If it can be a nice sounding name, and there is a good vibrant community there which is actually attractive to them. In fact, the apartment where I live in, one of our neighbors, husband and wife, they're not very old. They're about 65 only. They got their children married and they lived here for about 3-4 years. And then there was a farewell party and they said we are going to a place in Coimbatore because we want to go and live there. And they are very active. They are both of them are very active. They go for walks, and they can for another 10 years live independently here in the apartment. But they decided to go there, and that place is called Nana Nani in Coimbatore. Seems to be a popular place. I don't know, but
they're on TV all the time.
So like that, the awareness creation has to be more. We probably need if we have people from these homes on our call also, that has to be brought out that it's not such a bad place actually, and actually show how the insides of it is, where people are actually, living nicely. The place I go to is run by Little Sisters of the Poor. It's near Hosur, and it's near Brigade Road. It's on Hosur Road. And Jay is just opposite to our school.
Oh, okay.
Yeah, Little Sisters of the Poor. It's more than 150-year-old home where they have about 180 seniors. They have singles, they have couples, and they have. So it's a nice place basically, where they have their independence. And before I went there, I went with all kinds of preconceived notions. These are very poor people with a lot of poverty and this and that. Movie producers are there. One person used to come and talk to me every weekend, on Saturdays when I go there, and he just casually said, I used to be a very big producer in Tamil Nadu industry, and I made movies with Gemini Ganeshan, Savitri, and I said, wow, those were like the big stars of those years, and you actually were a producer. He said yes, and my children are producers now. All of them are well settled. I lost my wife 5 years ago. I didn't want to be a burden on them. It's my choice. I came here. Do you have a problem? I said, why should I have a problem? I'm happy. So I think, that shift has already happened. It's not that it's not happened. It has happened. That shift has happened. Okay. So people are more open to it. You are right. And people, when they can decide their career and they can decide their children's career and everything, by 60 years, it is more or less said that the children have started their careers, and it's not that they don't want to, stay with them. It's just a fact that you go on an assignment to USA and you are there for 5 years. You can't say no to that because that's your career. And similarly, you may get posted in Delhi or you may get posted in Bombay, or, it's a fact. So this kind of, heart-to-heart communication between the children and the elders is required, which is what happened with my neighbor, I can tell you. And they decided that, we will be in a safe place, because crime is a big problem in elders. Crime is a very big problem because the socio-economic gap is there. So that actually, is a risk. So the crime part is taken care. They are happy living among, the similar age group people. They have common things to talk, and they have their own circle of things to do. So they are very much comfortable living in that. So I would actually say that it's not like we are building from ground zero. 3-4 floors are already there. We need to just, bring those people together and build on top of it. Create more awareness. One person has connected with me. He wants to talk to me on LinkedIn. And, Dr. Arvind Kasturi, he mentioned, is the person who is behind the elder care facility in St. John's. 2 minutes, can I just quickly tell you about that? I had that, as a last comment before.
Yeah, sure.
So what St. John's Medical College has done is, St. John's Medical College, for those of you who don't know, is a leading teaching medical college, teaching hospital in Bangalore, in Koramangala. It's in the middle of the city. And it's a great institution. So community medicine is one of the subjects in medicine, in medicine, MBBS, and it's a department of community medicine. So they tend to work in the community. What this professor of community medicine has done, Dr. Arvind Kasturi, he has taken elders as a segment that he wanted to address. So people who live within 5 kilometers radius of St. John's Medical College enroll on a program, and this is about 25 to 30-year-old program that I'm talking about. You pay a small amount per year, some 3,000, 4,000 rupees, something, nominal amount, and you enroll on that program. What do you get for that? You get a team of doctor and nurse visiting you at regular intervals, taking care of you. Remember, in elder care, it's not just disease that you have to manage. You have to manage the regular, human being also. The social interactions are very important. So they do that, and even they find that there is a need for any kind of hospitalization, they are brought into the institution, St. John's, and their immediate, requirements are taken care of. Like I said, in the 60 plus age group, complications are, quite normal. Strokes happen, pneumonias happen, falling ill happens, they have falls. So many things are there, so they need to come in, get their problem sorted, and they need to go back into the community. So remember, what happens here is they are not living in a institution. They are living in their own homes, and they have, somebody to take care of them. So this connect between St. John's Medical College and the community around is a great connect. So this is a urban setting. They also provide care for a rural setting, which is in beyond Sarjapur, in a place called Megalai, and there they have a rural elder care facility. So the team goes from here every month, and then they have every week they have a day when all the elders around from those villages come there for their treatments, and they run outpatient there, and they also carry medicines which are given out to these elders. So they have an urban center and they have a rural center. These two centers are there. Now, interestingly, 2 months ago, Ashok Suta, the founder of Mindtree and Happy Minds and all these things, he actually donated a significant amount of money for old age medicine to St. John's Medical College. So that center is coming up, and in about a year's time, I think it should be live. It will be one of a kind center where they actually go and occupy. So you know that a regular medical wall will not have anti-skid flooring, and there won't be these guardrails on the side, and it's not a elder care friendly place. And if this person has neurological problems, if they have delirium, if they have dementia, it becomes all the more difficult. So this is going to be a dedicated elder care block with its own emergency, its own wards, its own ICUs, and we are really looking forward to this, and hopefully there we are also going to be able to create some of these certified care providers for the community.
That's wonderful.
Yeah.
So there are a couple of questions on training sessions which you have already addressed. You said that training sessions are a must, and stakeholders need to come in and step in to actually train the people to handle elder care. So I think we'll move on to the next. Nitya has an interesting observation. Nitya Murali. She says the downside is when elders are surrounded by other elders equally suffering, it might be too depressing for all. So when there were a few people who were saying that why not mix them up with the rest of the community? Why put them up separately? Where they just talk about their ailments, their aches and pains, and it becomes even more depressing. It would be nice to see children running about and enjoying themselves.
Well, that model has been tried. Some of these builders have come up with this idea. They put up 4 blocks, and one block is completely dedicated to elders. So they have the liberty of sitting in that balcony and watching the children play. Okay. But what is fun to somebody can actually be a nuisance to another person.
Yes.
Right? And I can tell you that since they have all these other cognitive issues, they actually prefer a very quiet, silent. They don't watch TV, they don't listen to radio because their vision is poor. They don't even read. It's mostly sleeping. They say, like in Tamil, they say Mudumai or the Kolandai Mari Parvam. So once you become old, you become like a baby. So all they do is feed, biological functions and sleep. That's all.
When young senior citizens and older senior
citizens, yeah, probably. If that is a choice they want to have, that if there are a few buildings like that which is there. And I mean, this is like for somebody who is from outside, probably, seeing this. But what I have seen in this Little Sisters of the Poor is among these 180 citizens, the residents, they actually have a lot of best practices amongst them they share.
Yeah.
So I was having, I was not feeling very well yesterday night. I had a little bit of indigestion, so I couldn't sleep. Yeah. And this other guy, tells him, you should have just taken some hot water. You could have, you would have felt much better.
Yeah.
And like that, they don't even come up to the. Or sometimes, there's a lot of bone humming, and there is no suffering as such. When they say you're surrounded by other elders equally suffering, they're not suffering. Initially, yes, there is a little bit of a shock. I mean, like I told you, here we get people from. Literally from the streets when police find somebody deserted in the railway station, or many times those people are left outside my clinic. They tell them we are taking you to the temple, and they come and leave them and go. And when I finish, I come out and see, and then the people who are there, they say, doctor, this is very normal for us. And then we have to tell them that it's not a temple, this is the old age home, and your children just dropped you and they're not coming back. So that initial grief is there. They can't believe that such a thing has happened. Then over a period, it takes a while for them to accept that fact and then slowly settle in. So those things are there. Hopefully we shouldn't end up in, those kind of situations. But overall, what I can tell you is amongst them, they actually enjoy become each other's company because they have common things to talk.
Yeah, that's right.
When they live outside in a community like this is where, it doesn't gel very well. Looking at kids running around, you are saying is okay, but kids are also very energetic and they keep shouting.
Yeah, noisy. Yes, noisy.
And it's a different thing. Yeah.
The next comment by Bharat answers that no one-size-fits-all model for elder care depends on social, economic, and cultural factors. Yes, it really depends upon their age as well as from where they come from and their tolerance levels. Their mental makeup also.
It's a choice.
Yeah, it's the choice.
It's a choice.
Raghunanda is asking whether do we have architectural standards, the builder community. Is there anything where people can conform to architectural standards and neighborhood development standards that we have to follow for geriatric care facility? So, most of the time they hear about interior finishes like handrails and flooring, but I'm sure there is much more. I think he has given a link also, but that link is not an Indian link. But is there anything for India where builders can follow and the stakeholders who want to build geriatric centers can follow?
I'm not aware. It's clearly out of my expertise. I'm a medical doctor.
Yeah. Okay.
But yeah, we can explore this and
yes. Yeah.
And I'm not very sure, what is the size of population that wants to actually go and look at that.
Yeah.
The secure accommodation idea is just an idea. It works in UK because the NHS pays for it.
Yes.
So if you do it in India, who's going to pay for it? And It's a big question. It comes with a must, yes.
Yes. There is a comment from Sivaram Rajagopalan. I think we need to look at keeping them active and engaged to prevent the rapid decline, both mentally and physically. I think these are extremely critical post-retirement, especially for those leaving the workforce. In some corporates, they have a post-retirement planning, a session itself where, the sudden change from active work life to retirement life, people get mentally disturbed. So, they do have training programs. Some additional work also around nutrition and wellness is also important. Probably some stakeholders can work on that apart from the training programs for, training the caregivers. So how to train the people who have just retired and entering the retirement phase, the active period to this. Probably some stakeholders can come up with some ideas and actually give them training programs. I'm sure the corporates do that. Some corporates do that.
That's a very interesting comment, because that phase, the transition from active life to post-retirement, the immediate aftermath, can also be very destabilizing and could lead to depression in the minds of these people who are entering into a senior citizen phase but still active, but haven't yet found something to occupy themselves. I mean, they have spent decades in doing what they were doing, and all of a sudden they are now retired, and they are not prepared to for the post-retirement life. And it takes a while before they begin to cotton on, if they do, not everybody does, to something that they are attracted to. So that phase can be, Dr. Thanga, this is a question for you, can lead to actually a period of depression, right? Which some might come out of, but some might not, and might accelerate their aging.
Thanks to technology and thanks to all these remote working options that have come up, it is actually easier now to do this than it was possible, say, 10 years ago.
Okay.
So these people are busy doing things that they are doing. So again, talking from my experience in the old age home, the teachers continue to teach. There is a science teacher who actually makes nice wooden models to explain electrostatic energy to kids. And the ladies who know to cook actually go and volunteer in the kitchen. They do the cooking. Nice. So they figure out things to do. And if it is more of professional skills like a chartered accountant or a financial analyst or any of those skills, and we had some naval officers also who were there. So each of them has got a skill set, and what they do is because this facility is free, it's not they don't pay for using the facility. So in turn they provide their services, what we call as Shramdan. No? Mm-hmm. They do that. So whatever they can, serving food, cooking, working, in the laundry, or doing the tailoring work, and whatever. And if they have any special expertise, like solar panels were required, so somebody stepped up for that. And there was a problem with water, so somebody who knew the civil engineering side, he came up with a good way of managing it. So it is a little community where everybody comes together and offers their little bit of expertise. And they're all happy because in the end, it is benefiting all of them. Mm-hmm. And we do have some doctors and nurses also there.
Right. So very interesting you say that, because during my time in the US, one thing I noticed was there's a large company called H&R Block, which helps in tax filings. Mm-hmm. Invariably, 9 out of 10 of those people, and this H&R Block, their time comes during tax filing time, just before tax filing. And 9 out of 10 times, the people at the H&R Block desk were all senior citizens who had, once upon a time been active doing something or the other, and picking up the reins of how to do tax filings on behalf of others. So this was a sort of an occupation that they would get paid for at that time.
Yeah. That is an opportunity for us also to create more awareness. Thank you, Shivram, for bringing this up. When we were in GE, we used to, GE volunteers is what took me into that old age home. It's one of our 25 projects in Bangalore. And then companies like HP and Microsoft and Bosch and so many companies come and support, including Bangalore Military School. Our guys also give all the excess food from the mess to them, so the community comes and supports them. And talking to the HR and letting them know that hey, we have these kind of people here who can actually do some amount of work on the side if you can give them something. I think it's something the leaders would be keen to support, either from their CSR activities or from their own company activities. They might be keen to do that. That's a very valid point, and yes, it is very much required, because it's not okay to just stop working one day and sit idle whole day after spending like 40 years doing something.
It probably calls for if any entrepreneur out there is listening, it probably calls for a network catering only to senior citizens who are just retired, for them to take occupations on a part-time basis that can give them an income and also keep them fruitfully employed on various things. We have a lot of those kind of ventures catering to the young crowd. You do part-time coding and part-time whatever designs and things like that, but focusing on senior citizens who are able to and who have the skills to bring to bear. It's something that's possibly attractive to a lot of citizens, senior citizens.
Yes.
Megalai, I think you missed one question. Good institutes for palliative training of attendants.
Yes. You can name a few doctors.
Yeah. I don't know if she's still there, but Karunashraya is a good institution.
Yeah.
They do regular palliative care trainings. Oh yeah, there she is. Karunashraya in Whitefield. St. John's Medical College has got a good palliative care program.
Yeah.
Baptist Hospital has got a good program in Bangalore. CMC Vellore has a very good program in Tamil Nadu.
Thank you.
So yeah, we have a good number of places where it is available.
Yeah. So I think we're running out of time. Punita, you want to say something because you've raised your hand? I think we have reached there are several comments here, but I think we're seriously running out of time. Punita, you want to say something? You can quickly say so. Have a doctor waiting. Yeah.
Yes, just two things quickly. That I think one of our attendees raised a point of attendant abuse. It is genuine. It is state-wisely different, and that's where the family should intervene and kind of mediate and ensure that they're not abused. Because it is always two sides to a coin. This is a genuine problem. And one question to Honorable Sir, Dr. Sir, in Delhi, is there a palliative care center, training center?
All India Institute of Medical Sciences.
That's the only one for the, sir, this is for the attendants?
No, if you are confusing between elder care and palliative care.
Palliative, not palliative, for attendants.
No. All that I told you is for palliative care. Palliative care is for taking care of people who are actually going to die within 6 months of diagnosis.
Yes, my apologies.
That is different.
Yeah,
that is different. No, it's okay because we were talking so many things. I'm sure it would have merged somewhere. Elder care, as of now, nothing is there.
Nothing. Okay. Thank you, sir.
Thank you. Thank you. I think Jay, we can wind up. You have your closing comments. Yeah.
Sure. Dr. Thanga, it's been a pleasure having you. It's been a wonderful discussion. I think all of us have gained a lot. To me, this particular topic has been particularly close to my heart from many, many years ago, over a decade and a half ago, when I spent a brief while in Canada and I was in Toronto. I was surrounded by senior care homes. Okay. This was amidst other commercial and apartment complexes. And I used to walk by every evening, and you can actually look beyond the colorful fences with bougainvillea and flowers and all that through the glass windows. And you would see them, depending on the time of day, you would see senior citizens, sitting around the table and having tea or whatever it was. And I used to think, oh, they're having a nice time. Okay. It all looked beautiful. But I can tell you this, not a week passed when the major newspaper in Toronto, there are two major newspapers, carried a story or other about abuse and financial embezzlement from these places. Now, let me give you a little brief background. Canada has a UK-style national healthcare program, but the private industry has an entry in only a few places, and one of them is provision of senior care. And these senior care homes always was in the news. I can't remember a week passed or a month passed when they were not in the news for all the negative reasons. So this problem is universal. So we shouldn't really think that India has all the bad uh, things. That we don't have a program is unfortunate, and we should try everything to create this ecosystem and help foster it so that it comes into being and we have standards and training, all those things that Dr. Thanga has spoken of, very vital, very necessary. And we as caregivers in the home, wherever we can, I think we should also take it upon ourselves to become aware of the issues. Dr. Thanga has pointed out to certain things that are not visible to most of us, uh, even in the company of adults, seniors. Okay, what is going on in their minds, and how can we look deeper so that they're not only are we giving care, but we do so in a manner that is comfortable to them. So, in that sense, this program has been extraordinarily personal and interesting for me. I hope it has for each of you. We also envision to have, at Thanga's own recommendation, to have more follow-on sessions like this, because what we have done today is merely peel one layer of the onion. And it is a very complex topic. And if ecosystem is something that needs attention, then we need several more sessions in the future. And so we would keep you posted. We would like to have more of these sessions which delve deeper into each specific facet of these problems. And hopefully all of you will join us and and create a better world for tomorrow. Thank you. Thank you, Dr. Thanga. Thank you, Megalai, from my side.
Thank you, Doctor. Thanks for spending your valuable time. So participants, thanks for your patience. We have overshot a little bit, but it was a very interesting topic. And like Jay said, we have several, it is like peeling an onion. So there will be several sessions. So watch out for the future sessions in LBN Tech Solutions Facebook page. And our next speaker for Healthcare Insights, we always have it in the last Saturday of every month, right? So for July, it is Professor Dr. R. Vaidyanathan, Professor in the Finance and Control area, IIM Bangalore. So mark your calendars, it's July 31st. And before that, July 2nd week, we have Dr. Sivaraman, the famous Siddha physician, the Siddha Sivaraman, Dr. Siddha Sivaraman. He has not confirmed the date, but it will be in the second week of July. So mark your calendars and please like the LBN Tech Facebook page for future events. Thanks for listening in, and thanks for all the lovely comments, and have a lovely evening, all of you.
Thank you, everybody. Bye-bye.